Thank you all for coming to our symposium session today. Didn't see that one coming. CFTR Beyond Highly Effective Modulator Therapy. My name is Holly Ann Jacobs. I'm a clinical pharmacist at the University of Utah Adult CF Care Center, and I'm joined here today by my co-moderator and chair, Lisa Lupsch, who is a clinical faculty member with Southern Illinois University School of Pharmacy in Edwardsville, and a clinical pharmacist with the pediatric team at Cardinal Glennon Children's Hospital in St. Louis. And I just have to share what a full circle moment this is for me. This woman is the reason why I got into CF Care. She made me cry when she lectured about cystic fibrosis in the second year of pharmacy school, and ever since then she's been stuck with me, mentoring me ever since. So this is a really wonderful moment to be sharing the stage with her. We have no disclosures. Our objectives today, we have three. First, we want to describe the impact of highly effective CFTR modulator therapy on the sexual and reproductive health of people with CF. Next, we will review newer management strategies for gastrointestinal problems in CF. And then lastly, summarize a family's experience with CF care teams and highly effective modulator therapy. We are doing things slightly different. We have 3 speakers instead of 4, so we'll have slightly longer sessions today because we felt that these topics were important and had the opportunity to share more. Our first speaker will be Lauren Kormlink. Lauren is a PharmD and board-certified ambulatory care pharmacist who earned the Doctor of Pharmacy from Southern Illinois University of Edwardsville. She completed a PGY1 pharmacy residency and PGY2 ambulatory care pharmacy residency at Indiana University Health Indianapolis. In 2017, she joined the University of Kentucky Adult CF team as the clinic-based CF team pharmacist. She is an adjunct member of the UK PGY2 Ambulatory Care Pharmacy Residency Advisory Committee and serves as a member of the Cystic Fibrosis Foundation Compass Advisory Board. Lauren.
Thank you so much for that introduction, and this is an SIUE reunion because I also attended SIUE and was inspired to go into CF by Lisa, so full circle moment for all of us up here. Today, I want to talk about some of the newer medications for the treatment of chronic constipation and review what data exists specifically for these agents in patients with cystic fibrosis. And then lastly, I want to discover how other centers are using these agents in practice. I think one huge takeaway for me every year at conference is just getting to see what other people are doing. Does it align with what we're doing at our center? Is there a different standard practice across the country? And I think the best way that we can learn is from learning from each other. So we'll end with some polling questions. So towards the end of the presentation, if you can have your phone ready and go into my specific session under the schedule, and you'll find the Q&A session to answer the polling questions. For a little bit of background, as we know, constipation is a very common complication of cystic fibrosis. And studies have reported prevalence of up to 42 to 73%, and this does increase with age. It's been difficult to really get a good prevalence of constipation because there hasn't always been a standard definition of what constipation in CF means and how we distinguish constipation from distal intestinal obstructive syndrome. So in 2005, there was a meeting of a work group to define constipation specifically in CF to make it easier to compare different studies and literature across the board and get a good idea of the prevalence. So the definition is a couple components. First, the patient must have symptoms of either abdominal pain or distension, along with either a decline in the frequency of bowel movements over the last few weeks to months, or increased stool consistency over the last few weeks to month. And the last factor that must be present is that these symptoms must be relieved by the use of laxatives. And so this definition has helped us to really pool literature and find better information about prevalence of constipation in CF. The pathophysiology is really multifactorial. So we have this slower small intestine transit. We have altered composition of the intestinal contents with that same thick, sticky mucus that we see throughout other organs present in the GI tract. There's an altered pH of the GI tract as well as altered gut microbiome. And then of course we have the abnormal electrolyte and water transport that occurs due to the faulty CFTR channel. So historically, we utilize some non-pharm treatments like promoting hydration and exercise, encouraging patients to increase fiber in their diet. And then we have used some over-the-counter medications like our non-stimulant stool softeners, polyethylene glycol, maybe even some stimulant laxatives in severe cases. So for a long time, we didn't have a lot of great options to help these patients with chronic constipation. So in the last decade, we've seen some new emerging therapies for constipation, and they do vary slightly based on what we use them for. There are some that are for opioid-induced constipation. We have others that are more for chronic idiopathic constipation. So we'll focus on a couple of these groups. We'll talk about the intestinal secretagogues, which are broken into two groups. We have chloride channel activators and GCC agonists. And then we'll also touch briefly on our type 4 serotonin receptor agonist as well. So to oversimplify the mechanism of our intestinal secretagogues, we have two different chloride channels that are pertinent on the cell surface. So the first one is this type 2 chloride channel represented by the blue channel. And you can see this channel is on the intestinal lumen side of the epithelial cell in the GI tract. When a chloride channel activator, such as lubiprostone, binds to this channel, it encourages chloride to flow into the intestinal lumen. With our GCC, or guanylate cyclase type C agonists, these activate the GCC channel, which in turn transforms GTP into cyclic GMP. And cyclic GMP has a couple different purposes in the intestine. So the first one is that it can act directly on pain fibers in the submucosal space. So this can help with some of our abdominal pain and other pain-related symptoms with constipation that are due to this visceral hypersensitivity of these pain fibers. So we can see some improvement in the pain associated with constipation. The other function that cyclic GMP has is that it can act directly on the CFTR channel, and this can, again, increase chloride secretion into the intestinal lumen. And we know that if we get more chloride into the intestinal lumen, sodium will follow the ion gradient, and then H2O will follow. So these things together can help to treat some of the pain as well as to just increase GI motility. The first one is lubiprostone. It was approved by the FDA in 2006. So these agents have been around for a while, but we've had questions about whether there is a role of these agents in CF therapy. This medication is available in two strengths. We have an 8 and a 24 microgram capsule. One thing that I think is good to know is that there is low systemic bioavailability with these intestinal secretagogues, so we don't have to worry about a lot of systemic absorption. And some patients feel a little more comfortable with medicines that may not be systemically absorbed. So that is one factor that is important with these medicines. And they aren't studied in pregnancy, so we really have to weigh risks and benefits if a patient were to become pregnant or if we're interested in starting during pregnancy. The two indications that are FDA approved for lubiprostone are chronic idiopathic constipation and irritable bowel syndrome with constipation subtype. And it's really restricted to being studied in patients 18 years and older, but we will talk a little bit about what data exists in our pediatric population for those of you who are working with our pediatric patients. Dosing does vary by indication. So for chronic idiopathic constipation, we're typically using 24 micrograms by mouth twice daily. This is the target dosing that we are using most commonly in my clinic for treating chronic constipation in CF is the chronic idiopathic constipation dosing. But there is the dosing for irritable bowel syndrome with constipation that is 8 micrograms by mouth twice daily. And administration should be taken with food and water, and this is important to mitigate some of the side effects that we'll talk about. Interestingly, although there is not systemic absorption, patients who have different levels of hepatic impairment do tend to have more side effects from this therapy. So there are dose adjustment recommendations for starting doses, depending on if the patient falls into Child-Pugh B or C. And it is okay to titrate up as tolerated to full dosing. It just seems that they're a little more sensitive to the standard dosing at first. And the only contraindication is with a current mechanical obstruction. So if a patient is having any type of dios or obstruction event, we would want to make sure that that is completely resolved prior to initiating any of these medications. The most common side effect that we see with lubiprostone is nausea, and it can occur in up to 29% of patients. So this is a pretty common side effect that we can see. The risk of this side effect increases with dose. So if a patient can't tolerate the higher dose, it may be reasonable to try to back up on the dose, go down, and see if the patient can tolerate at a lower dose without having nausea. Of the 29% of people in the clinical trial who reported nausea, 4% did report severe nausea, and 9% did have to discontinue. So we do have a pretty high discontinuation rate due to nausea with lubiprostone. The second most common side effect is diarrhea, which occurred in up to 12% of people on the 24 microgram dose. And of those 12%, 2% reported severe diarrhea and 2% did have to discontinue. So it is important to make sure we're educating our patients about some of these side effects, what to expect when they start therapy, and helping them to deal with them if they occur. So for our pediatric colleagues, if you want to snap a photo to check out these articles later, I don't have a ton of time to go into all the details, but the long and short of it is that lubiprostone has been looked at in people less than 18 years. The data is very conflicting. So what we've seen is that the side effect profile seems to be about the same in our pediatric population as what was published for adult clinical trials. However, some studies have shown efficacy of these agents and some have not found significant efficacy. So it's really a patient-centered decision, but I would encourage you, if you practice with pediatrics, to check out these articles and kind of make a decision for yourself about when it might be helpful for a patient, really just weighing the risks of side effects versus the potential for it to either work or not work and impact the patient's life. So I think we could definitely see a place in therapy for pediatric patients, but there's just not a lot of data out as of yet. Next, we'll talk about our GCC agonists. So the first one is linaclotide, and it was approved by the FDA in 2012. We do have some various dosage forms on this capsule as well. And again, we have minimal systemic absorption and no good studies in pregnancy. As with our other agent, it's only really been studied in patients 18 and older as far as formal clinical trials for FDA approval. And it is FDA approved for CIC and IBS-C. Our standard dosing with this one is nice because it's once daily. So if a patient is struggling with twice daily dosing, this could be an agent to decrease their pill burden. It should be administered 30 minutes prior to the first meal of the day. And dose adjustments really are only required if it's a tolerability issue. So for patients who have side effects, we can try to decrease the dose from our standard 145 microgram a day dose to the 72 microgram dose. And some patients may be able to tolerate better on the lower dose. The GCC agonists as a whole are considered contraindicated in patients less than 2 years old. There is a recommendation to advise against use in patients 2 to 6 years. And so we're still learning a lot about these in pediatrics, but what was noted is that there may be an age-related increase in GCC receptors that can cause severe dehydration. And so it's been studied in some animal models, and some authors feel comfortable using it in those patients over 2 years old, but there's not adequate information to further investigate use in patients less than 2. The most common side effect with linaclotide is diarrhea, and this can occur in up to 16% of people on the 145 microgram dose. Looking across at the placebo, the reduced dose 72 microgram, and the 145 microgram dose, we did see higher discontinuation rates due to diarrhea as the dose was increased. So this is why we have that data that it may be helpful to decrease the dose if a patient has diarrhea. As far as some of the other side effects, abdominal pain and flatulence were the only other 2 side effects that occurred in more than 5% of patients. And it's sort of hard to know if this was due to the medicine or if this was a function of the constipation itself, but there were about 1% of patients that had to discontinue therapy due to reported abdominal pain. And again, in children, here are a couple references for you if you're in pediatric practice. We saw about the same results with these. It's really conflicting. Some studies have shown increase in spontaneous bowel movements. Some studies have shown that there wasn't significant improvement in symptoms. And so it's just a matter of us getting more information out there to feel comfortable using these more regularly in patients under 18 years. And then our second GCC agonist is plecanatide. It was approved in 2017 and is approved as only one dosage form, a 3 milligram tablet. We still see negligible systemic absorption, and we don't have a lot of information about use in pregnancy. For plecanatide, we still have the same CIC and IBS-C indications, and the dosing is the same regardless of indication. We don't need any dose adjustments. It can be administered with or without food, so a little bit easier as far as administration requirements. And plecanatide specifically is contraindicated in the package insert for patients less than 6 years for the same reasons that we saw with linaclotide. The only side effect that occurred in 5% or more of patients with plecanatide was diarrhea. And it typically presented within the first 2 to 4 weeks of initiation. And for many patients, it was transient. So after a few weeks of taking it, the symptoms did resolve. However, some people did have very severe diarrhea within the first 3 days of initiation, and discontinuation rate was about 2%. We know even less about plecanatide in pediatric patients. However, there are 2 studies one is currently enrolling, one is completed but not yet published results. So hopefully soon we'll know a little bit more about possible benefits of this agent in our pediatric population. Next, we'll shift gears and we'll talk about our type 4 serotonin receptor agonist. Some people may remember previous medications in this class that have been approved and also subsequently removed from the market due to safety concerns, specifically with cardiovascular side effects. And so the important thing to know about prucalopride is that there was extensive in vitro cross-reactivity studies that were completed to make sure that this was a specific enough binding to that type 4 receptor that we would not see those cardiovascular effects. And so we know it does bind specifically, and we don't have the same concerns that we've had with some of the previous medications that had been approved. With prucalopride, it binds to the type 4 serotonin receptor, which in turn activates the excitatory neurons to release acetylcholine, and this causes the smooth muscle cells to contract and increase our GI transit. This one does have systemic absorption and bioavailability of greater than 90%, so unlike the others, we do see this be systemically absorbed. It's only indicated for chronic idiopathic constipation, and again, it's not studied in patients less than 18. The dosing is 2 milligrams by mouth once daily, and it can be taken with or without food. It is primarily renally excreted, so dose adjustment should occur for patients who have creatinine clearance less than 30 milliliters per minute, and the reduced dose is 1 milligram by mouth daily. And again, contraindications we see for any patient who has a current obstruction or any structural or functional disorder of the gut wall that puts them at higher risk of perforation. We see side effects a little more common with prucalopride, which makes sense because it's systemically absorbed. So headache, abdominal pain, nausea, and diarrhea were all very common side effects. And about 70% of the patients who reported diarrhea experienced it within the first week. But we did see most patients that experienced it did resolve in a few days. The discontinuation rate due to diarrhea, however, is lower with this agent than some of the others, with only 1% discontinuing due to diarrhea. 2% of patients had to discontinue due to nausea and 1% due to abdominal pain. So overall, even though the side effects may be more common with this agent, the discontinuation rate is not higher than the others. And there is one study looking at prucalopride in children 6 months to 18 years, and there was no difference compared to placebo in children's functional constipation symptoms. So now let's get into the CF-specific data. We know a little more background about the medicines, but how can we apply this to our patients? So there are a few things that have been published. In 2010, a group published a case series of use of lubiprostone in patients with CF. And then the same group in 2011 actually performed a single center pilot study of use to try to have a more proactive approach. And then in 2018, the next publication occurred regarding animal models with use of linaclotide. I think it's important to note the dates of which these medications came out and the dates of which some of these trials have occurred, because obviously a lot has changed in CF care since 2010. And I think it's why it's important to revisit this topic is that historically, some of these agents were thought to not be options in CF because if we're acting on a CFTR channel and if we know we don't have functional or enough CFTR channel on the cell surface, how could that medicine ever work? But now we're in a point that we may be seeing these extrapulmonary benefits of medications like our triple modulator. And so we need to revisit some of these to say, now that we know we're improving the amount and the function of our CFTR channels, could these be more impactful on our practice than we previously thought? So our first case series by O'Brien and colleagues in Arkansas, they looked at specifically lubiprostone because of it acting on that type 2 chloride channel. They speculated that the other agents that act on the CFTR channels would likely not have impact. And so they chose this to try to address this underlying factor that contributes to constipation in the CF population. And they had 3 patients who had already been started on lubiprostone, so we'll just go through and talk about each of these 3 patients. The first patient was a 34-year-old white female. Her genotype was unknown, and her past medical history included chronic constipation and hypothyroidism. At baseline, she had been on polyethylene glycol 17 grams twice a day, and when lubiprostone treatment was initiated, the chronic idiopathic constipation dosing was selected at 24 micrograms by mouth twice daily. On follow-up at months 4, 7, and 10, the patient reported she was still taking both the lubiprostone and the polyethylene glycol as prescribed. She reported daily bowel movements and denied any symptoms of constipation. And on physical exam, there was no palpable stool noted. When the patient came back at 14 months post-initiation, she reported that she was still taking the polyethylene glycol, but she was only taking the lubiprostone as needed because she felt like she was having loose stools with the twice-a-day dosing. However, she did say she still had good control of her constipation, she hadn't had any obstruction events, and she had no palpable stool on physical exam again. So she was told to continue with the dosing as needed since it was working for her. And at 19 months, the patient came back. She was taking the polyethylene glycol but had completely stopped lubiprostone. And she denied feeling symptoms of constipation. However, palpable stool was noted on physical exam. And so she was instructed to restart the lubiprostone at 24 micrograms twice a day. And that takes us up to the time of publication. So I don't have data to follow up on what happened after she restarted. There were some monitoring parameters that were reported, and we did see a slight decline in FEV1 and in BMI. However, again, this is the pre-modulator world, and so we expected to see about 1 to 3% decline in percent predicted FEV1, so it's probably in line with the standard. So no safety concerns that we can identify from these monitoring parameters for this patient. Our second patient was a 22-year-old white female. She was a Delta F508 homozygote, and she had a little bit more of a complicated past medical history. She had chronic constipation, several incidences of distal intestinal obstruction syndrome, pancreatic insufficiency, depression, attention deficit disorder, dysthymia, and of note, she had at baseline chronic nausea that she had been reporting. At baseline, her bowel regimen was polyethylene glycol 17 grams twice a day, and her lubiprostone was started at 24 micrograms twice a day after a hospitalization for diose. So after her acute event resolved, she was initiated on lubiprostone as well as the increased dose of polyethylene glycol to 3 times a day in an attempt to prevent further hospitalizations. She had a more complicated course, but overall for the first 12 months, she had 8 clinic visits and reported that she only had constipation on 2 occasions, but on both of those occasions, she had also said she had self-stopped her polyethylene glycol. And she did report nausea at 6 out of 8 of these visits. However, the nausea was not reported to be worse than baseline, and she didn't feel that it limited her ability to continue with the lubiprostone therapy. At 16 months, she actually had a gastrojejunal tube placed due to increased abdominal pain, which had caused her to use opioids, and she had experienced worsened nutritional status. So it was decided that she needed a feeding tube to help her nutrition. And at 17 months, she continued to have this abdominal pain, but she denied that it was due to constipation. She really felt that it was more due to the tube placement. But she was, again, non-adherent to her polyethylene glycol and using doses of methadone and hydromorphone, which could be contributing to constipation. So about 2 weeks later, she ended up admitted for severe constipation that didn't respond to treatments at home. And at that time, the decision was made to continue her current bowel regimen, but also add on methyl naltrexone to address any opioid-induced constipation that she may have had. She did have some changes in her lung function and her BMI. Her lowest BMI was 19.9, but she was starting to recover after the placement of her feeding tube. So probably not due to the lubiprostone therapy, just due to her overall health status that we saw some of these decline. Then our last patient was a 22-year-old male with an unknown genotype, and he had cystic fibrosis, intermittent constipation, pancreatic insufficiency, and a history of malnutrition. Interestingly, with this patient, he had not been on any baseline bowel regimen, but he was hospitalized at an outside hospital and discharged after an intestinal obstruction event without any bowel prep regimen. And at the time that he followed up in the clinic, the CF team decided that it would be beneficial to go ahead and try to treat him with lubiprostone at 24 micrograms twice a day. At 6 months, he had been taking the lubiprostone as prescribed and denied any symptoms of constipation. And at 16 months, which was his next follow-up, he reported that he had been taking the lubiprostone intermittently about 2 to 3 times a week. And he reported he just thought it was a little too strong for him, but he had good control of his symptoms, had denied any nausea, preventing him from taking it, and he hadn't had any subsequent obstruction events. Again, no major concerns with monitoring. We actually saw his lung function and BMI increase over time. So the mean duration of therapy with these 3 patients was 17.3 months at the time of publication. And the authors concluded that combination may still be required for some patients who have severe constipation. With our non-cystic fibrosis population, we may pull back on all of their other bowel prep regimens when they start these agents. But for those who have this history of dios or severe constipation, they may require more control. It's interesting that several of the patients did change their dosing based on feeling like it was too strong or they were having loose stools, and so that makes me wonder if maybe those patients would have done better if they stopped their bowel prep regimens or only used polyethylene glycol as needed in combination with full dosing of lubiprostone. None of the patients reported adverse effects, and despite that nausea is reported as the most common side effect, even the patient who already had nausea at baseline did not report any change in her nausea symptoms. And all of these patients did report at some point in their treatment some improvement. And so that's why they went on, the same working group went on to try this pilot study to see if we could get a bigger patient panel to find out more information of the use of lubiprostone. It was a single center interventional study that included people 18 years and older with CF and constipation. They had to be on chronic therapy with scheduled doses of some laxative or bowel regimen. And they had to score at least 1.5 on a questionnaire called the PAC-SIM, or the Patient Assessment of Constipation Symptoms. So this is a 12-item questionnaire that can be used to assess symptoms of constipation in 3 domains. And lower scores are typically better. And if we see 0.5 to 1 point improvement, that is considered mild to moderate improvement in symptoms. The other option, if the PAC-SIM was not 1.5, was that patients could have had a less than 3 on the Bristol stool scale for stool consistency. And it really targeted a population of patients that were more stable. So exclusions included anyone with current or recent obstruction within the past 6 months, any patient who was pregnant or breastfeeding, who had serum creatinine over 1.8, liver enzymes over 3 times the upper limit of normal, anyone with an FEV1 of less than 40%, people with frequent hospitalizations for exacerbations in the last 6 months, or anyone who is listed for lung transplant. So we really targeted our more stable patients in this study. As far as our baseline characteristics, there were 7 total patients that were enrolled in this pilot study, and the average age was 26, with about 43% being men. For our FEV1% predicted, the average was 83%. And for baseline constipation therapies, we saw a few patients were on only scheduled polyethylene glycol, some who were on a scheduled polyethylene glycol in addition to milk of magnesia. We had 1 patient who also used Senecide tablets as needed, and there's 1 patient that was actually already on lubiprostone at baseline. For the intervention, patients were monitored with a 2-week run-in phase and encouraged to be adherent to their bowel regimens, and then given 4 weeks of lubiprostone at 24 micrograms by mouth twice a day with meals. There was an option in the protocol to decrease the dose to once a day if nausea was intolerable. And the primary outcome was the change in number of spontaneous bowel movements per week by patient report. So the patients were given diaries to log their bowel habits in, and this was how they obtained primary outcome. For secondary outcome, the study group looked at changes in the PAC-SIM, changes in the Bristol Stool Scale, adherence by capsule count, which was collected at both 2 and 4 weeks, and adverse events that were collected at 2 and 4 weeks. This chart shows our outcomes of the study, and so you can see there was no statistically significant difference in spontaneous bowel movements per week or the Bristol Stool Scale. However, the PAC-SIM score did have statistically significant improvement, and this was driven primarily by 2 domains, those of abdominal symptoms and stool-related symptoms. For adverse effects, again, out of the 7 patients, we didn't see a ton of adverse events. The most common was nausea, as we would expect. This was reported in 2 subjects, and 1 of the subjects reported improvement over time. So at 4 weeks, nausea had resolved. One thing I do want to point out is there was 1 patient that reported some transient chest tightness that was relieved by chest physiotherapy, and 1 patient also reported shortness of breath. So this is something to consider in our population. This was not previously published with other studies of lubiprostone, so it's something that we may need to educate patients about or keep in mind if patients have similar complaints. It was a limited study. Obviously, it was a short duration, a very small sample size, and overall the population was very healthy. As well as having no placebo group. So we have some limitations, but we also did gain some information. Some patients did have improvement in their functional symptoms, and we're here for our patients. So if there's a way to make them feel better and it's relatively harmless, then this could be a good option. So their conclusion was we still need data, but some patients may qualify and benefit from this therapy. So then nothing was published with any of these agents until 2018, and I'm no expert in animal studies, but the main takeaway from this study was that linaclotide was studied in CF mouse models, and they found that gastrointestinal transit was increased, and luminal fluidity was increased through inhibition of this sodium hydrogen exchanger 3 mediated sodium absorption. So there may be an underlying benefit beyond just the action on the CFTR channel. Further studies are obviously needed. We need to know more about using linaclotide in patients, but this may be a therapeutic target for patients with CF with intestinal manifestations. And I think it's interesting that not a lot has been published since modulators have come out, because I really think that linaclotide or other GCC agonists really might be an option for us in patients who are on modulator therapy. I will say personally in my practice, we are using linaclotide quite frequently, and we've seen overall good results that hopefully we will have published at some point to get some information out there about the use of linaclotide. Most patients that we've put on it have had benefit and have not had significant side effects. However, in 1 patient who did have significant diarrhea, dose reduction did work. So I think there's a chance that these are agents that need to be revisited. And with that, I want to find out what everyone is doing at their centers. So if you could get your phone out, get your polling ready, we can see if anyone else is using some of these agents, find out if anybody else is using linaclotide along with us at UK. So our first question is, does your center use any of these newer agents for treatment of chronic constipation in patients with CF? So majority of those responding actually said no, but we have about 12 people who said that they are using some of these agents in practice. By show of hands, how many people in the room are in pediatric practice? Okay, so a lot. Most of the room is in pediatric practice, so that may be the reasoning for not quite as many people using these in practice, since we do have even less data in our pediatric population. So for those who are using these agents, which agent are you using most commonly? Is it lubiprostone or Amitiza, linaclotide, which is marketed as Linzess, plecanatide, which is Trulance, or prucalopride, which is Motegrity?
So for those of you that joined us late, it's in her specific session on the app. If you want to join, you've got 20 seconds to join this poll. 16.
Okay, so this is interesting. The most commonly used agent was linaclotide or Linzess, which we don't have as much information for. Lubiprostone, that does have the most published information. We had about 11 people who say they're using that in practice, and then a few who have seen prucalopride or Motegrity. So this is interesting. I'd be interested to hear if you're a center that's using linaclotide. I'd love to partner with you and try to get some sort of case study published. My email will be on the last slide, so please reach out to me. I'd love to partner with you. We started really using linaclotide out of the need for insurance authorization. So some insurances would cover Linzess but not Amitiza, and so that's why we initially started using it. And we have one more polling question. I'm curious to know, if you're using these newer agents, how are you adjusting the patient's other bowel regimens? And so there's a lot of options here, so I'll read them off to you before we go to the timed slide. Do you continue their other bowel prep as previously prescribed? Do you discontinue other agents at initiation of new treatment? Do you reduce the dose or frequency of the other agents empirically? Do you consider reducing or stopping only if loose stools occur, or does it just depend on the individual patient? We lost option E, so I guess you don't get to do patient-specific care. That was probably going to be the most common answer, I would guess, too. So,
Polling.
So the majority of responses is consider reducing or stopping if loose stools occur. And I think this is fair. The information is still conflicting. There is some data that patients may need these agents in additional to other treatments. Some patients may be able to dose reduce or to stop completely. But for most people, it probably just depends on their individual situation and what they're comfortable with. I've had some patients that I've talked to about pulling back on some of their treatments, and they have said they would basically rather see what happens regimens before pulling back because they know how bad it is when you have to have a hospitalization for dios. And so I think it really depends on the patient and a conversation of what do they feel most comfortable with. Obviously, if a patient is having loose stools, that's a reason to pull back on the other regimens. I would say pulling back on other treatments prior to dose adjusting these newer agents is probably a better strategy. But again, it's all relatively new to the CF space. So I think that we're still learning a lot about it. This is a shameless plug for a different study that is a multi-center study that we're trying to survey pharmacists. So if you want to scan the QR code with your phone, it's a survey about pharmacist involvement in clinic, and we're trying to get an update of a previously published survey to see how CF care, including pharmacists, has grown over the years. So please consider taking the survey. And if you don't have time to snap a picture or to scan the QR code, Dr. Bob Kuhn will probably hand you a printed QR code for you to do at your convenience at home.
All right.
I can take any questions.
Yes, go ahead and start putting your questions up if you have any. We have 2 to start with. So at what point do you recommend starting a newer agent? And is there a time that you will discontinue it if the patient is or isn't improving?
As far as when to start, I think it depends on the patient. You know, we have a lot of patients that we've started on because they've maxed out all of their options. They may be taking polyethylene glycol 2 to 3 times a day. They may be using stimulant laxatives 2 times a day, and they're still having symptoms. So for patients who are not responding to standard treatments, that would be one group. The other group I would say is we try to initiate in anyone who ends up having a hospitalization for dios, because that's a population that we want to prevent further hospitalizations. So if someone has had a dios event in the past, even if they're stable, you may consider starting it in that population. As far as when to consider stopping, our luminally active agents, our intestinal secretagogues, really have a pretty quick onset. So within a week or 2, the patient should be feeling improvement in symptoms. I try to get patients to give it about a 1-month trial to see if they have improvement. And if they report improvement, then we'll continue. If they don't report improvement, or if they're having side effects, we can talk about dose reduction for side effects, or stopping if it's just not working. But most patients that we have put it on have had benefits, so I haven't had a lot of people want to stop due to not being effective.
For the sake of time, I would love to ask, since there's a lot of pediatric folks in here, a question about trialing Linzess in preteen or in teens, and getting it approved through insurance. So I'm sure if you have an answer, otherwise if we can pull the group.
Yeah, so I practice on the adult side, so I don't have specific experience with that situation, but what I will say is if I extrapolate from other authorization experiences, the PA will definitely get denied and you're gonna have to appeal it. I think it's a matter of writing a letter, including some of the literature that shows potential benefit and safety. And just in general, that's my standard approach to any off-label appeal that I do, is to provide the insurance company with as much data to review as possible so that they can see that there is data to support this off-label recommendation. But if anybody that's using linaclotide in the pediatric population has anything to add, I would welcome anyone's pediatric expertise here. Yeah. So just to repeat that for everyone, it is sometimes possible to get it approved off of the appeal process. However, as a name brand only medication, it may have a high copay still. And for off-label use, the copay card is not allowed to be used. And so there may be some cost prohibition with getting it approved off-label.
Okay, we'll take one more question here. Why, it was the voted up one, so you got to vote 2 if you want to hear this question. Why is Amitiza your first choice over Linzess?
Amitiza is not my first choice over Linzess. My first choice would actually be Linzess because it's once a day. It has a little easier administration, and we've seen really good results with it. It kind of came out of necessity because of insurance in our region preferring it. So I think standardly, some people may prefer Amitiza or lubiprostone, because we have those studies in patients with CF that show it could have some benefit. I think with linaclotide or Linzess, it's still a question mark, but from my standpoint, I have seen great improvements with it, so we do go to it first line at our center now. So I think it probably just depends on the person, what their opinion would be. Some may say there's no data to use Linzess, so we're not going to use it, but I really think in this post-modulator world, it has much more of a role in therapy. So I don't think that I personally prefer lubiprostone or Amitiza, but some may, just based on what data is available.
Great. All right. All right, we're going to switch gears here. And yes, thank you, Lauren. There are more questions, so hopefully we can discuss them in the app.
All right, our next speaker is Dr. Natalie West. She is an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine at Johns Hopkins University. Her area of clinical and research expertise is cystic fibrosis. She received a master's in health science degree in clinical investigation from the Johns Hopkins Bloomberg School of Public Health through the full-time graduate training program in clinical investigation. She is one of the national investigators that has been integral in the design of 2 large clinical trials coordinated through the Cystic Fibrosis Therapeutic Development Network, which is examining treatment of pulmonary exacerbations, known as STOP and STOP2. She has been awarded the CF Foundation Clinical Research Scholars Program, which is a 3-year award designed to train physicians to design and conduct clinical trials. This study funds her research in evaluating the role of inhaled antibiotics in CF. Lastly, she is one of 5 women who founded the Sexual Health, Reproduction, and Gender Research Working Group, whose aim is to determine the gaps in knowledge around health issues that impact women with CF, to identify future research priorities, and to begin to develop the infrastructure needed to efficiently move these research priorities forward. With that, I'll turn it over to you, Dr. West.
You got fans.
When I was asked for a bio, I thought you were going to summarize that and not read all of that. So I'm sorry you guys had to listen to all of that. Oh, sorry. Okay, thank you. All right. Hello, everyone, and thank you so much for coming. I see some familiar, friendly faces in the audience. So I'm going to be talking about considerations for contraception, pregnancy, and lactation for those of our patients on highly effective modulator therapy. I do have some disclosures just that I have as part of the Women's Health Working Group, the sharing group. I have a lot of grant funding that is supporting a lot of our studies in a lot of the conversations we're going to be talking about. So you may have seen this in some other talks, but there's multiple of us who are wanting to urge the CF Foundation to commit to ensuring that future meetings are held in locations where elected leaders understand the importance of reproductive freedom, gender-affirming care, and the sanctity of the physician-patient relationship. Thank you. So briefly, very briefly, because I think most of the audience knows how wonderful Trikafta ETI is, but we'll kind of go over the importance of the health outcomes and the improvements. We'll describe current fertility issues in CF, and then also describe the impact of highly effective modulator therapy on contraception, pregnancy considerations, and lactation. So great, we know that ETI greatly improves outcomes. So for the purposes of this talk, highly effective modulator therapy includes ivacaftor, which is Kalydeco, and then elexacaftor, tezacaftor, ivacaftor, which I will call ETI, which is Trikafta. And so improves lung function by about 13%, decreases rate of exacerbations by about 65%, improves weight, et cetera. And so really now, highly effective modulator therapy is available for the majority of all people. And so if you look at the projected growth of adult CF population, so we're right around maybe 22,000 adults with CF in the US, that's projected over the next 10 to 20 years to get almost to 30,000. And the reason I show this is that that means a lot of people, more people are gonna continually think about parenthood. I would be remiss if I said that I didn't want to talk about the 10% who are not eligible for HEMT, so I really appreciate all the researchers in the CF Foundation who continue to strive to get a cure for all. So let's talk about fertility in people with CF. This is your happy morning picture. So this is anatomy in the normal population without CF. So we will quickly run through this. So what I really want to point out is that that in normal male anatomy, sperm is starting in the testes. You have the vas deferens, which helps bring it to the seminal vesicles and goes out the end of the penis. On the women's side of things, eggs are stored in the ovary. They come through the fallopian tubes. If there's a happy sperm waiting to join, then they attach together on the wall of the uterus, and then that's kind of normal anatomy. So what's different with CF? So starting over in the male side, missing the vas deferens. So there's no connection from the testes to the seminal vesicles. So when I talk to my patients about reproduction and issues, I kind of say, hey, you're basically going from point A over a river to point B, and you're missing the bridge. There's just no way to get there. And then typically there is sometimes atrophy of the epididymis as well as the seminal vesicle, which we'll talk about why that's important. On the female side, because of the defect in CFTR, it becomes a very acidic environment, which creates thickened mucus. So kind of similar to the lungs, kind of same thing in the uterus and the cervix. They have very thickened mucus, which basically makes it so sperm can't swim to where it needs to go. And so we'll talk first about fertility in females. So we just saw that really the reproductive anatomy is similar to those without CF. But the things that really affect female fertility in CF is that CFTR dysfunction, as we talked about. There's also delayed puberty and ovulation and the nutritional issues, which have been made better by HEMT. But most females with CF can become pregnant. And there was a study looking at that there's like a 35% subfertility rate, which basically means a little different than infertility, just means there is a kind of a longer period where you're trying to get pregnant, you're just not conceiving, but not technically considered infertile. And up to 50% of pregnancies in females are actually unplanned. And so how could potentially modulators help female fertility? So they likely, we already know we have better health and nutrition when our patients are on highly effective modulator therapy. Case reports and just patient reports have shown us that the cervical mucus has thinned out, just like we kind of have the purge once we get on Trikafta from the lungs. Kind of a similar thing happens to females through the cervical mucus. And then we have better bicarb excretion, so that acidic environment goes away, so you kind of normalize the pH there. And so, and actually in the original ivacaftor trials, about 2% of our patients there actually became pregnant, kind of pointing us that there might be a clue there. And then there are certainly cases of females who were previously diagnosed as having infertility who then became pregnant after HEMT. So I've got I feel like I had 10 people pregnant within the first couple of months being on Trikafta who had a similar, lots. So now I kind of am like, okay, if you don't want to get pregnant, we got to really talk here. And then I'll point out Andrea Rowe at Penn has actually done a study of cervical mucus quality. And I really like this visual. I think it's really kind of cool. This is a heteroscopic image of the same individual, and this is looking at the uterine wall prior to ivacaftor. So you see this thick mucus, and then this is 3 months after, where it's just completely cleaned up and doesn't have any mucus there. And so that was about 3 months after ivacaftor. So let's talk about men and how HEMT may or may not be able to help our men with CF. So because of the absence of, on bilateral sides of the vas deferens, about 98 are considered infertile. And so again, it's because there's no bridge to take the sperm where it needs to go, but there's also absence of the epididymis and then atrophy of the seminal vesicles, which we'll talk about in a second. So ways we can diagnose that this is the issue: physical exam. Me as a pulmonologist, not sure I can actually do that, but we really rely on semen analysis, looking for quantity, quality of sperm, and also you can do ultrasound, which is non-invasive, to see if there's a presence or absence of the vas deferens. And I think the good thing to note is that the combined absence of the vas deferens does not, it results in infertility but not sterility. So there's a lot of actually help that we can give to our men with CF. And actually tomorrow at 3:30, I'm moderating a session, and one of the, I interviewed, it's pre-recorded, one of my patients who's a male, him and his wife, who went through this and kind of tells their journey if you guys are interested. And so talking about ejaculate actually in men with CF and the impact of CFTR modulators. So the majority of fluid actually comes from the seminal vesicles, and we know that CFTR is there, and then actually the seminal vesicles are actually atrophied. So the actual volume of ejaculate is quite low. But there have been case reports that after starting highly effective modulator therapy, there's been testicular pain, and it's thought to be related to actually just increased volume that they're not used to. But can we improve or increase their fertility? So likely not, because highly effective modulator therapy, miraculous as they are, cannot regrow a vas deferens. And so there's been no cases of improved or rescue fertility that we're seeing. However, there's some in our pregnant ferrets who there was a small study that were homozygous or heterozygous for the G551D mutation, which was the first mutation that ivacaftor was tested upon and approved upon, that the ferret kits, or the babies who were exposed to ivacaftor in utero the whole pregnancy, actually had their vas deferens. So kind of pointing to something possibly in the future. So we'll move on to contraception. Oral contraceptions in the general women population is the most commonly used contraception in the U.S., approximately almost 10 million women. And then Emily Godfrey and colleagues did a survey in about 2017-18 at 3 centers, about 150 patients, CF ages 18 to 50, and asked things about contraception, pregnancy, and tied it to the registry. And some kind of overall results is that, again, the combined hormonal contraception was the most common, so 42%, and this will become important when we talk about modulators and how they may or may not interfere with contraception. Bayer methods, 30%, and then 24%, almost a quarter of our women actually do not use any methods. And so here, looking at the impact of CFTR modulators on contraception, and really we're looking at drug-drug interactions. So ivacaftor, tezacaftor, and elexacaftor have no interactions with our hormonal contraceptions, but lumacaftor does. So when lumacaftor, ivacaftor, which is Orkambi, came out, and that most people who had homozygous for F508 were eligible, we really had to counsel our patients, our women at that time, that their hormonal contraception may not be as effective. And fortunately, since ETI came along, there's very few people, if any, that are on Orkambi anymore, although I know it's not approved everywhere in the world, so there still may be some women out there that are still on Orkambi that we have to keep this in mind. And then I wanted to point out CASE for CF, which is Assessment of Contraceptive Safety and Effectiveness in CF. So that's Maura Aiken and Emily Godfrey. And they just finished this up, and we were a site that participated, and they did a survey of quite a few adults and women, and looking back at their history of contraception, pregnancies, miscarriages, and then tied it to the registry to look at some other complications as well. And so Emily has a oral presentation on Saturday, and she was kind enough to give me a slide of their top line results. I don't want to totally spoil everything, but if you're interested, 3:30 on Saturday. And so obviously we now have a big increase in pregnancies after Trikafta, and pretty much found in their participants that contraception use is universal. Only half of pregnancies actually ended up in live birth, so I think that our miscarriages, abortions are likely underreported, and unplanned pregnancy is common, which is what we kind of found in earlier studies. So let's talk about pregnancy. So I'd like to point out, even though we're talking about pregnancy, if your patient doesn't have that option or doesn't want to go down that route, maybe they have an FEV1 of 25%, aren't comfortable, I think it's really important to talk to our patients about the other options. So adoptions, foster care, surrogacy, et cetera. And so these are 3 studies really just kind of showing that our patients have a lot of desire to become pregnant. So there was a retrospective multi-center study in Europe and the UK with over 600 individuals with CF greater than 18, and almost half of them had attempted pregnancy. Tracy Kazmersky's and colleagues did a study really looking at our younger individuals, ages 15 to 24, and really asking them a lot of questions about sexual reproductive health and pregnancy. And the vast majority of our young CF patients said they want to have a child in the future. And then in Australia, there's a smaller study about looking at a qualitative study, looking at a group of women with CF whose mean age was about 32, and over half of them had tried to get pregnant, but 100% of them said they wanted a child. And so I think this is really showing that our patients really want to have children, and they're going to rely on us to help walk them through the process. So good news, this is also one of my favorite slides, that pregnancies have drastically increased after ETI. So on average, the past 2 decades, it's been about 200 a year. And then all of a sudden it was 619. And then in 2021, the latest number is 675. And there was a joke in the TDN meeting that it may have just been the pandemic and everyone was sitting around at home and had nothing else to do. But I more think it was ETI, so. All right, so pregnancy and impact of pregnancy on outcomes. So, there's been a worry in the past, okay, we've got someone whose lung function is lower, they get pregnant, they're gonna be immunocompromised, what is that gonna do to them? So Chris Goss and colleagues did a registry analysis, which is older, but did not show any survival disadvantage in pregnant women in CF versus those that were not pregnant. And then Mike Schechter looked at the epidemiologic study of CF, also a little bit older, and did show that women with CF who became pregnant had more illness-related visits, more exacerbations, including IVs, and lower quality of life scores, but did not have an accelerated disease progression or increase in mortality. So preconception care, what do we tell our patients? How can we help them when they come to us? I think the first and foremost is really important is carrier screening of their partners. So if they go out into the world and ask their PCP for genetic testing for my husband, Joe, then maybe that my PCP may not know that there's actually really dedicated mutation analysis for potential carriers of CF, and I might only get him tested for 23. Okay, he's not a carrier. Well, if I go to the dedicated labs that have the full analysis of over 2,000 mutations that cause CF, I might find that my husband Joe has another mutation, which is really important because if he's a carrier and I'm a person with CF, we have a 50% chance of having a child with CF. So really kind of talking very thoroughly about that. Early referral to maternal fetal medicine, particularly if lung function is less than 60%, there's some risk there, which we'll get into, but having someone who's highly specialized in potentially high-risk pregnancies would be really important. We always talk about nutritional optimization, making sure they're on the right and correct pancreatic dosing, vitamin supplements, and then glucose control is a big one. So almost nearly 50% of our women with CF have CF-related diabetes, which can cause hyperglycemia, can cause issues with the fetus, and increased risk of a C-section. So really making sure we're on top of that. And if they don't have diabetes, certainly screening them with the oral glucose tolerance test. So what is the impact of lung function on pregnancy? So this is kind of what I was getting to the point when someone has moderate to severe disease, less than 60%, there is an increased risk of preterm delivery, a need for a C-section, and actually low birth weight for the infant. Raksha Jain actually showed that there was a 2% decline in FEV1 in pregnant women who were not on highly effective modulator therapy. And so what are we allowed to keep on during pregnancy? And this is Raksha Jain and Christina Montemayor just did a recent review. It's in Breathe 2022. And there's actually a lot of things that we can still continue. And for those of you that have EPIC, we have a great smart phrase that we just give out to our patients so that they know what they can and cannot take. And I think what's important to note here is Dornase alpha or pulmozyme and hypertonic saline inhaled. And then if you look at this, inhaled antibiotics, these are some of the things if they were given IV, we would not be very excited about. But since they're inhaled, there's little to no systemic absorption. So we can use the majority of these things in both pregnancy and lactation. Azithromycin really the data has shown there's no risk or low risk. And is generally, even by our OB colleagues at Hopkins, don't mind that at all. And of course, our fat-soluble vitamins and pancreatic enzymes. And then we're gonna get into the data on that we have available for the highly effective, all the therapies actually. And so Christina Montemayor and I surveyed many of you, actually. Thank you for any of you who filled out our survey. But about a year ago or so, we surveyed the CF community about what CF clinicians and pharmacists and nursing are comfortable doing. And so one question we asked was, by trimester, how comfortable are you continuing some of the CF chronic therapies by trimester? And if you look at the first couple rows, the first four, pancreatic enzymes, hypertonic saline, Dornase alpha vitamins, pretty much 80% or higher throughout each of the trimesters. When you get to azithromycin, it gets down to about a third for each trimester, even though it's really shown to be no risk or low risk. And then what you'll find on the highly effective, or the highly effective modulator therapies, so ivacaftor and then ETI, these were higher, 70% or higher, and a little bit lower for the Lumiva and Teziva, which I suspect probably is because they have lower efficacy, and so the risk-benefit ratio was not as clear for those two. And so what happens in pregnant women when they stop their CFTR modulators? So this is 3 cases of dramatic decline following ivacaftor withdrawal, so I'll kind of walk you through. So this top one on case 1, this is the month since starting ivacaftor. So right here, this line is when this participant started ivacaftor. And then this is their lung function before and then after. The arrows denote pulmonary exacerbations. So as you can see in this one, case 2 and case 3, lots of exacerbations before starting ivacaftor. And then as you typically would hopefully see, lung function improves after starting it. But then this little asterisk, which is kind of hard to see, this is where they stop their ivacaftor, maybe during pregnancy, for instance, and you can see the dramatic decline. And so this person had the dramatic decline, restarted, FEV1 went back up. This person tried to stop it several times and each time declined. This person unfortunately stopped it and had to be intubated and later died. And so these are just 3 earlier case reports. And then there's also additional case reports in Trikafta, those that were in the phase 2 Trikafta trial, that after they finished it, lung function declined in 7 out of 10 and had exacerbations in at least 5. So there were several international surveys conducted by members of the women's group, and the first one, and this says we, it was not me, it was Ed Nash and Jennifer Taylor-Kauser. A lot of the slides we share between ourselves, so I should have not put we. But completed an international survey, and a lot of US participants were included on individuals with CF who were pregnant and kept on IVA, Teziva, and Lumiva. And so here's their baseline demographics. You can see that the majority were on IVA, just most likely because it had been approved the longest. And then the FEV1, not surprising because that's the highly effective modulator on this list, was higher. And then they had been on their modulator for an average 15 months, 17 months, 3 months. And Teziva had just been approved during the study period, which is why that's less. And so here is the percentage of women is on the y-axis, and then first trimester, second trimester, third trimester, and then all put together. The green is IVA, blue is Lumiva, and then the yellow is Teziva. And these are just the percentages of women that stayed on their modulator throughout that. There was 2 pregnancies, one that resulted in a miscarriage and one that was terminated for health reasons in this group. And really the outcomes of this is that the miscarriage rate for women was 4.7. The rate in the general population is 10 to 15%, so certainly not any higher than we would expect to see, and actually lower. And then when any of them actually stopped their modulator therapy, because that was their personal choice, they had a health decline in 9 of them that actually then they resumed back on the modulator. And there were no complications seen in the infants in this study. So then they repeated the study in women who were pregnant on ETI more recently. And that was an additional 47 women. And the FEV1 here is about 75%, and they had been on ETI for at least 3 months on average. And here again is a similar graph. So of the 45, most of them were on it at conception, a few had stopped, and then the majority of them were on it the first and second and third trimester. All trimesters about half, and then about half for lactation. And so kind of combining all of these, we kind of talked about the top that there were 2 maternal complications in that first study that were deemed secondary by the treating physician they thought was secondary to CFTR modulator use. One was a pulmonary exacerbation, which I think we could all argue against, and one was AML, which generally is not associated with a modulator, and likely is not associated. And then there were no modulator-related complications seen in infants. In the newer study in ETI, kind of same thing. There was clinical decline in the 6 women that stopped. And then there was one maternal complication deemed related to ETI, which was cholecystitis, which we have seen in our non-pregnant patients on ETI. I've certainly seen that at Hopkins. And then 2 other complications deemed unrelated. And then there were 3 complications in infants deemed unknown. One was a transient rise in transaminitis, but there was also, I think that infant had been on antibiotics. There was other reasons it could possibly be. And then 2 congenital malformations. So kind of overall putting these all together was about 135 women studied. The miscarriage rate was much lower than the general population. And then the cessation of modulator therapy resulted in clinical decline. And so going back to our survey that Dr. Montemayor and I did, and so what are we doing during pulmonary exacerbations and how should we be treating them when they're exacerbating? And so this is just kind of in general what people are doing. So looking at the top section, this is for preferred treatment for a mild exacerbation. And that's usually what we define that in the survey as an FEV1 drop less than 5% with more mild symptoms. And the majority of you out there are treating with oral antibiotics or sometimes an oral antibiotic plus an inhaled antibiotic. And then for treatment for a severe exacerbation, so more like a drop in at least 10% in FEV1 with more severe symptoms, the majority are more going for an IV antibiotic plus an inhaled or 2 IVs or 2 IVs plus inhaled. And that really, that goes kind of what we generally treat with an exacerbation. So it doesn't really seem like we're doing too much different generally with our pregnant women. But what can we use to treat during our exacerbation? So I have a great relationship with our maternal fetal medicine physician, and I will text her and be like, okay, so-and-so's in clinic, they're sick, what can we do? So really, this is also a great table in the recent publication by Roxha Jain and Christina Montemayor. But really the ones we really need to avoid are fluoroquinolines, aminoglycosides, and Bactrim. Bactrim, I think, arguably can be used in different trimesters, certainly not in the first trimester, but I have been allowed to use that in certain times by my colleague. And then, but really remembering that even though we do not love aminoglycosides, but if they're inhaled, they can be used in pregnancy. And I've certainly been able to do that successfully without issues in multiple pregnancies. And so going back to our survey, pregnancy care, and there really is variability in how important providers think a topic is, but how comfortable we are in discussing it. So looking at CF medications, 97% of providers out there thought that that was important to discuss during pregnancy, and 71% felt comfortable. So there's still some questions out there. Looking at CF-related diabetes management, so insulin and oral glucose tolerance, everyone definitely agrees it's important, but only 18% are really truly comfortable discussing it. And then looking at other issues that don't really involve medication is preterm delivery, pregnancy termination, miscarriage. We really, as a general community, don't have a lot of comfortability, probably because of lack of knowledge in discussing these issues. And lactation. So how do CFTR modulators impact the breastfeeding infant? So we'll see all of these modulators are present in breast milk, and so really kind of counseling our patients about nursing. And so the main issue and component that we have to be careful about is ivacaftor. The others seem to be okay. And cataracts are observed in juvenile rats. And so that's the thing we have to kind of counsel as probably more of our pediatric colleagues, but all of our pediatric colleagues, if they don't do CF, don't know about this. So me as an adult provider, I like to tell my moms, hey, tell your pediatricians that this is what needs to kind of happen. And so here is a case report of a woman who was on lumacaftor, ivacaftor, and this is all of the levels. So this little diamond right here, which you can kind of barely see, is a level in the cord blood. So that was at birth, so you can see it's definitely obviously present. And then the highest lines in both of these are the mom. And then the this line right here is the square, is the infant with the breast milk in diamond, and it's a little bit reversed down here. And so what you can see is pretty much in the first several months of life, it's pretty routinely elevated at pretty stable levels. And then in this particular infant at day 150, they were only having, their feeds only consisted of 50% of breast milk and got formula, other things, so that's why it starts dropping off after that. And I'm sorry. And then you'll see that what I've highlighted down below are some liver enzyme abnormalities, which could be related to, obviously, the modulators. However, around day 29, I think it's pretty common, pediatricians correct me if I'm wrong, to have some mild elevations at this time after birth. And then this infant was on antibiotics around the second time, so it's unclear whether it was related to the modulator, but out of safety, they did stop the modulator. And then looking back at those two retrospective surveys that we showed you on the moms that were on ivacaftor or any of these modulators during pregnancy, 69 of those ended up infants being breastfed while were on the modulator, and there was no report of any LFT abnormalities in their breastfed infants. And 6 of those infants had dedicated assessment for cataracts and were not found to have cataracts. And then this is just another study kind of showing the same thing. There were 3 mother and infant pairs all on ETI. And you'll see that these are the different components. So the green is elexacaftor, red is tezacaftor, and blue is ivacaftor. This is maternal ETI concentrations, infant, breast milk, and then these are all at the time of birth. And basically just showing that these all kind of, another study showing that these all kind of remain mainly stable throughout post-delivery. So what do we tell our moms for monitoring? So cataract screening should be done, and was this a question you were going to ask me? I can skip the slide if you want. Cataract screening should be done in those babies that were exposed to modulators in utero and via breastfeeding. Although the risk is low, should be done probably yearly. And then newborn screening in those who continue CFTR modulators throughout pregnancy. So sometimes there may be a false negative on the newborn screening. So if the father is a known carrier or their status is unknown, really considering testing the infant for CF with a sweat chloride genetic testing. And so a little bit about our women's health research group I wanted to highlight. So we, the 5 of us, reached out to the CF Foundation, put in a grant, and it was funded in 2019. So Jennifer Taylor-Kauser has served as our chair for the last 3 years, and Raksha Jain as our vice chair, and then Tracy Kazmersky, myself, and Moira Aiken. And over the last 3 years, we have added 4 additional working group members. Alex Wilson, who's a research coordinator with Jen Taylor-Kauser at National Jewish, 2 community members who have CF, Jackie Schoberg and Madeline Paransky. And then we recently added a psychiatrist for a mental health piece, Anna Georgiopoulos. And then in our charter, we've always said the chair gets 3 years and then we kick her out. Not out, she just steps down. So we want to thank Jennifer for her fearless leadership over the last 3 years. And then recently Raksha moved from vice chair to chair, and then we elected Tracy to be our vice chair. And we renamed the group, instead of Women's Health Working Group, we renamed it to Sharing. So Sexual Health, Reproduction, and Gender Research Working Group. And really our goal is to identify the gaps in knowledge and really create some clinical studies, determine research priorities, and really begin to develop the infrastructure to move these priorities forward. And if you go on cff.org, we have a website that has a lot of information on it. We just actually formed a first subgroup is the Men's Health Working Group, which is led by Tracy Kazmersky. And then coming in 2023, we're going to be putting out information. We'd love for any of our community members to join us in a transgender non-binary care. And so we've talked about a lot of the large retrospective studies in all CFTR modulators, but I wanted to highlight Mayflowers, which is a current prospective study that is going on with Raksha Jain and Jennifer Taylor-Kauser. And so we're going to be looking at maternal health, delivery outcomes, fetal outcomes in about 300 women. We just started enrolling a year ago, and we just got the news we have enrolled up to 100 patients already, which is fantastic. And this is kind of what it looks like. So we're trying to get some data from the mom, like really perfect scenario would be first trimester, second trimester, third trimester, and then at delivery, and then following mom and baby for 2 years. And at deliveries, so we're part of a PK study. We're actually getting PK levels of modulators on cord blood, mom, baby, and breast milk. So there's several sub-centers that are doing that, and then there's a continuous glucose monitor sub-study as well. So here are outcomes looking at all the things you would think: lung function, exacerbations, weight change, mental health, looking at any sort of delivery complications, and then in the infant, obviously cataracts, birth weight, any other kind of NICU stays, things like that. Tracy Kazmersky just got funding from the NIH and the CF Foundation to do a really long parenting study. So she's got a retrospective piece, but also then a prospective piece, and she's going to be following parents, new parents, for 7 years, looking at how being a parent might affect health of an individual with CF. So conclusions, highly effective modulator therapy can improve fertility through increased overall health, nutrition, decreased cervical mucus. We all know that the majority of our people with CF are eligible, and we know that the number of pregnancies are increasing. And really, I think highly effective modulator therapy is really well tolerated in pregnancy and lactation and looks to be very low risk for mom and baby. And I'd like to point out too, in the session that I'm moderating tomorrow, so this first speaker is going to be Tracy Kazmersky. She's going to be giving us more information on parenting and what she's done so far and what she's looking to do. And then Raksha Jain, I didn't want to include it because I didn't want to steal her thunder, is actually giving us more information on studies on highly effective modulator therapy in pregnancy and outcomes. And then Chris Fortner is going to be giving us more information on outcomes in babies who are born to moms that have been on CFTR modulators. So there is more data than I presented today, but I didn't want to steal their thunder. So please come to that session if you're interested. And I'm happy to take questions.
Awesome. Thank you, Dr. West. Okay, I like this one. Has any work been done on improving provider comfortability in CF with pregnancy-related topics?
Yeah, that's a great question. So, and that's one that I think us as a group are working on, and particularly Tracy Kazmersky is heading up. So that is one of our goals is to say, okay, where are the gaps here? Because we've already shown that we don't have a lot of, we need better help with getting knowledge tests. I mean, we're pulmonologists, we're pharmacists, we're nurses. We are not OBs generally. So thinking of ways to more educate our providers on those type of topics and kind of in the works.
How soon after birth would you recommend cataract testing?
Yeah, so I think the timing of that is up in the air, to be honest. I don't think we know, but I would think generally within a couple months, and then at the year mark, and then letting the ophthalmologist decide whether a follow-up thereafter is needed.
Some of the women at a CF center were already taken off ETI by their OB provider before the center had learned about their pregnancy. Do you make any preemptive recommendations to continuing ETI if they become pregnant till they talk with you?
Yeah, so if I know that they're planning and it's not one of these surprise pregnancies, I talk to them about, I show them the data, I pull up the graphs, I actually I'm a visual learner, so I like to tell my patients about it. And then we've had full-on discussions with our OB partners. So the one OB, she likes to see all of our patients, so we actually are lucky in that respect. So I've given her the data and she is fully supportive. So I think it's really, one, having preemptive discussions with your patients, but if you know they're OB, we can't blame our OBs that don't do CF of not knowing all of this because it's pretty a secluded world. So giving them the data as well has been helpful.
Excellent. Yes, there was a question about postnatal monitoring. So I guess we could review the postnatal monitoring of infants who have been exposed to HEMT.
Yeah, so I can go back to that slide. This one, yep. So yes, the postnatal monitoring, just to review, cataract screening in those infants who had been exposed in utero to CFTR modulators. And again, I don't know that we know the timing, but generally within the first couple months, and then repeating it at 1 year, then kind of going from there. And then the important thing also is newborn screening, that if we don't know what the father's genetic screening type is, or if he's a carrier, we would definitely proceed to sweat testing and genetic testing to make sure the infant doesn't actually have CF.
Excellent. We have time for another question if anybody has something they want to shout out. thank you so much.
Thank you, guys.
Yep. I'm going to welcome up a family to the podium. Very honored to have the Krugers join us today from St. Louis. They've been part of our CF Center for most of Raina's life. There has been a transition throughout it that I think we'll discuss a little bit. And with that, we're so happy that you guys are here. Yes. I don't know that there's anything, right? You got slides?
Yeah.
Okay.
I don't have a disclosure, so you can skip that.
Sure. This down. Just a little.
Good morning, everyone. Thank you for being here today and allowing us to be a part of this. We feel very honored. So our last CF event was in 2019 before the world shut down, so shout out to our Greater Illinois chapter. But my name is Jenny Kruger. This is my daughter, Raina. I'm the mother of 4 children. 2 of them have cystic fibrosis. I have a 21-year-old daughter named Mackenzie. She actually just made me a grandma to a little guy named Dion. A 17-year-old son named Sean, and then my 2 youngest, 15-year-old Raina, and then a 5-year-old Kylie. They both have the double delta F5U8 mutation. They were born 10 years apart, and they have very different stories. This is mostly thanks to Kylie's early detection, early care, and of course, early access to modulators. Raina's gonna start off by giving a quick version of her story.
Okay, hi. Okay, so my name is Raina, and I was born in November of 2006. So in Illinois during this time, CF was not included in the newborn screening, and it didn't become mandatory until January of 2008. So I was a mostly healthy baby. I just had some troubles like gaining weight, although I did have a lot of upper respiratory infections and ear infections, and therefore I was on a lot of antibiotics for that. So when I turned a year old, my pediatrician decided to do a bit of lab work just to make sure that everything was okay since I was so small. And this led to me seeing a kidney doctor and a genetics doctor. And while I was at the kidney doctor, they asked me some questions, and basically they decided to order me a sweat test. So I took the sweat test, and of course, it was positive. So, so the same day, at 15 months old, I was diagnosed with cystic fibrosis. Had my first, I met Dr. Noyes and Judy, and had my first of many admissions for CF. So I did already have some lung involvement, but my biggest hurdle was growing and gaining weight. This alone is a very difficult obstacle with cystic fibrosis. But something later happened that led to us something that led to us finding another reason of why I was having trouble gaining weight. I was diagnosed with celiac at 3 years old. So that didn't help, for sure. I had many admissions, so over the years, I had a lot of admissions. So I had to get a lot of PICC lines, which was not good for my veins, and they were eventually, there's a picture of me with my G-tube. Yeah. So they were scarring too much, and when I found this out, I was scared. I didn't know what would happen, and I thought that I would be stuck using IVs for the rest of my life, which would ruin the veins in my hands as well. But then they told me an option that I could do, which was getting a port. So, so they gave me, so I agreed to it. So in 2015, I had the port placed, and they gave me an option of where to place it, and I personally thought this was really cool. So I could choose where I wanted it. They told me the pros and cons to every place that it could be, and I decided to do the lower left side of my chest. Everything was great, but then 2016 came, and it was a particularly hard year for me. I was having a cough that we were having trouble controlling, and I was culturing stenotrophomonas. We tried to eradicate it with oral antibiotics, inhaled colistin, and eventually a hospital stay for IV antibiotics. We decided that I would need a daily prophylaxis dose of doxycycline, which did finally seem to help. I'd already been considered colonized with Pseudomonas and was cycling Toby too. And so I started on Orkambi as soon as I could when I was 10 in 2016. And I was into YouTube then, so here's a clip.
Can you get to it?
Yeah. Here's some pictures. Yeah, I took a picture, I think this was first grade with all the medicine that I had. Yeah. Here's the video. I was 10.
What is up, guys? It's RMK Buddy talking here, waiting for a new video to be uploaded onto YouTube. Okay, so this is just an update video. I feel fine now, but I'm gonna have to take my pill again pretty soon. Anyway, earlier today, it's just so bad. So, the first thing that happened was I was tired because I was up all night coughing and coughing and coughing and coughing. The second reason was that, well, I wasn't only tired and coughing and coughing and coughing. I had a little headache and my tummy didn't feel good. That's it really, but I started feeling nauseous later in the day. Thinking of it, I feel a little nauseous now. So I try to be energetic. I forgot one important thing. Chest tightness, shortness of breath. Well, it's not really that it's shortness of breath, but like chest tightness. I couldn't really breathe as much as I wanted to, and so, I just didn't really feel that good at all, so,
Yeah.
Perfect.
What is up?
One more time. You should give us a report on your YouTube progression.
So that was me. So anyways, I had the purge as everyone had warned about, and I stopped doing my tube feedings temporarily because I felt terrible and couldn't tolerate them for the first week. But my mom noticed that I hadn't lost any weight after talking to the doctors, I officially was able to hold my tube feedings after such a short time on Orkambi, and I never started them again. So, I had my tube removed within a year of being on Orkambi, but I was still culturing Pseudomonas and stenotrophomonas. And we couldn't remember exactly when, but I did stop culturing stenotrophomonas for a while after being on the daily dose. And my mom and the doctors were concerned about resistance, so we stopped the doxycycline. I ended up back in the hospital, and my culture showed stenotrophomonas again. Dr. Noyes and Lisa came into my room to let us know and to talk about us restarting daily doxycycline. The one downside I've never been totally sure we can blame Orkambi on is I did have a lot of intermittent abdominal pain while on it. So in 2018, I started Symdeco, and I hadn't been able to clear either of the bacteria in my lungs. But Symdeco did start helping me stay out of the hospital and recover from viruses faster and without prolonged cough and additional antibiotics. And that's when we really started hoping to be able to eradicate the bacteria in my lungs and stop some of the daily meds. So also on Symdeco, I didn't have any abdominal pain, which was amazing because, yeah. So when I was 13, Trikafta was finally approved for my age group. So I started taking Trikafta in December of 2019. And at the time, I was still on treatment for Stenotrophomonas and Pseudomonas. But after a while, I eventually stopped culturing Stenotrophomonas, and was able to stop taking daily doxycycline, which was amazing. But I'd really love to be off Toby. I still culture Pseudomonas on and off. So I do have to still cycle the Toby podhaler, but I'm thankful for the podhaler option over the nebulizer. Thanks to Trikafta, I was able to have my port removed after a year of not using it. Bad news that on Trikafta, on Trikafta, I have had some more random abdominal pain, but not as much as when I was on Orkambi. And I did end up getting diagnosed with pancreatitis at my local hospital in 2021, but I haven't had many more issues since then. My routine to stay healthy has changed through the years, and currently I do airway clearance twice a day, albuterol, hypertonic saline twice a day, pulmozyme daily, Toby podhaler twice a day every other month, Creon, omeprazole, azithromycin, MVW complete vitamin, a calcium supplement, and of course, Trikafta.
Hold on, bravo for all of those words, right? Amazing. Stenotrophomonas.
So obviously Raina's been through plenty in her 15 years, but still we know we're blessed because she's had it easier than a lot of others. Kylie, she was born in May of 2017. She's the baby of the family by 10 years, and she has a very big personality, I think because of that. She's sweet most of the time. She has a very big stubborn streak, so that comes into play later in her story. She was diagnosed with a newborn screen, so we started care right away, as obviously we were set up with our CF clinic, and they helped her get her screening results quickly. So in contrast to Raina, she had the early diagnosis, started care right away. But even as an experienced CF mom, there was a lot I didn't know about infants with CF, such as things like they could have applesauce and Creon beads. I had no idea. Putting salt in their bottle, that was all very new to me. Then came Zantac and vitamin D and albuterol. When Kylie turned 2, Dr. Noyes approached us about starting Orkambi. I'll admit that I was hesitant just based on how healthy she had been. She hadn't really cultured anything. She hadn't had any hospital stays. Her weight, had been pretty okay. So I was resistant to it. We said no. So then at 3 years old in 2020, she did culture atropomycin-resistant Pseudomonas, and she was started on Caistin and oral antibiotics for that at that time. She continued to cough, not a horrible cough, but she just kept on, having a cough. And she did end up with a hospital stay. So at that time, we did go ahead and start the Orkambi. She also started on pulmozyme. But with her starting on the Orkambi, I think so young, she didn't have a purge, she didn't have abdominal pain. So I think, obviously, in hindsight, the younger the better for that. So just, everybody knows the weight benefits of being on Orkambi. So with Kylie, though she does not like taking her medications at all, particularly Creon and antibiotics. So every time she does get a cough, we're so thankful for our CF team because they are able to, work through that with us and find different antibiotics that, are maybe more palatable or less, volume. Or just maybe even less dosing time and twice a day instead of 3 times a day, and just helping work with us on things like that. A post about how horrible the Caistin was. Yeah, there's no cute picture of that. Eventually, she tolerates it. So this is after the hospital stay, being compliant finally. But we're getting along with that. So when the movie 5 Feet Apart came out, I had a lot of concerned people ask how I handled having 2 children with CF, since obviously they shouldn't be near each other. The most honest answer I could have given for that is that we planned to do a lot better than we did. So you know, having sisters with CF, they're obviously very close. And, you know, eventually it just turned into all hands on deck. So, you know, I took whatever help I can get. I still do my very best to keep like nebulizer equipment and stuff like that together. They did eventually do treatment together, you know. It was actually really helpful because Kylie is so stubborn. So having Raina as a role model was super. You know, even though things seem fairly normal with having the siblings with CF, that burden of knowing that Kylie culturing the tobramycin-resistant strain was probably having another person with cystic fibrosis in the house. So that can be tough sometimes. But I feel like we've been very lucky with just with timing, receiving good care, and having access to medications. The one last thing I'm going to touch on is being one of the biggest challenges I feel like of having a family, 2 working parents, 2 chronically ill children, my 2 children that probably felt like they didn't get enough time growing up, was dealing with insurance and pharmacies. It's literally a full-time job. I'm not sure how everyone else's insurance works, but with the meds my girls need and insurance dictating where I can fill the meds, I currently deal with 3 different pharmacies. So we have a pharmacy for just the daily meds, specialty meds, and then a 3rd specialty pharmacy because the pharmacy that I have to use for specialty meds doesn't carry Cayston. And then also getting, you know, vitamins directly from MVW Complete, and then also having to buy things over the counter. I could obviously be forgetting something in there, but this is where I need to give the biggest thanks to Lisa and Kelsey and our CF team. Kelsey especially, I mean, yeah. She takes stuff off my plate every time I come in. And what I'm talking about, like, instead of telling me, hey, there's this program you can use, she will literally fill it out for me, you know. So thank you. And thank you. So, and then Lisa for, you know, all the time working with Raina and Dr. Noyes and Judy, just always working with us and telling us, you know, why I need to take these medications, what they're for. I'll always remember Lisa coming in and talking about Pulmozyme being like fruit ninja in the lungs and chopping everything up. So that was cool. It's super helpful tool with Kylie because when I try to get her to do her Pulmozyme, we talk about fruit ninja and get her all pumped up. So
it's not trademark. You can use it.
We're just so thankful to have such a team that cares and, you know, gives us time. So, you know, also I'm a nurse, by the way. So in my nursing life, I just want to thank, I was told there's going to be a lot of pharmacists in the room. Can't talk. But when I was in nursing school, I was having trouble on a test doing just a drip rate calculation. I wrote in, just call pharmacy because, you know, because you guys have the answers about the calculations, the medications. Just thank you for being there. Where else am I going with this? Oh, I just want to again thank Dr. Noyes and Judy, the entire CF team at Cardinal Glennon, for seeing us through this journey. For me, what sets this team apart is communication. Due to an insurance change with my employer at the beginning of 2021, I wasn't able to take my children to the CF clinic where they had been seen for their entire lives. I cannot tell you how stressful that was and how it's just insurance dictating everything is hard on a family that has chronic illness. We were lucky to have a CF team kind of local to us. I won't mention their names because I didn't talk to them ahead of time. But they were kind and they did, you know, help us out when we needed it. But just one of the biggest differences I found was just ease of communication. And I think maybe that even has something to do with being a bigger clinic, but being able to directly call a number and talk to someone. It's major because getting through to some of these other places that I've dealt with, you leave a message and you might get a call a couple days later. It's when you need something that is very stressful wait. So just calling, and usually the same day, I hear Judy's voice, you know, this is Judy from Cardinal Glennon. It's relief, really. So kind of how we got back to Cardinal Glennon is Raina was having an exacerbation. She had a couple of x-rays in a row that, weren't quite right. And we were just having trouble getting through to the clinic we were being seen at. And no hard feelings with them, so I don't want them to take it that way if they're listening, but I was having trouble. So I called Cardinal Glennon because that's where we had always been. And within a couple of hours, Judy had called back. And they scheduled her for that following Monday, a bronch on Wednesday, and after the bronch, they scheduled her admission. And it just felt so much like a good combination of professionalism and family, and it is definitely the right place for my family to receive care. And I kind of went through this, note where I am. So I definitely want to I don't want to leave anybody out. Thank you, Dr. Noyes, and Lisa, and Kelsey, unfortunately, was not at work this day. So the entire CF team, Judy, Pat, Eileen, everybody, you guys are absolutely wonderful. So thank you.
Yeah. Okay. Do we have any questions? All right. I'm not seeing any on the chat here. Any questions for the family? I will start. I guess, what do you think the biggest hurdle in your medication is right now? Besides Toby. Yeah.
The biggest hurdle in my medication, honestly, the time it takes to do everything in the morning. Cause I have a 0-hour class that starts at 7:25 in the morning, band.
Awesome. Yep.
I have to if I wake up and take a shower or something, I have to wake up at 5 a.m. It's terrible. It takes so much time. It's very difficult. It takes a lot of stamina and determination, but we get through it. Everything's okay. It's just a big hurdle, but yeah, that's probably the biggest hurdle.
At 5 a.m. is quite early.
Yeah.
You have any questions? All right. We still, oh, good, thank you. Yes.
Were you able to stop any after the breakup? Still a pretty long list of
The doxycycline.
Yeah, I stopped the doxycycline.
Well,
after starting Trikafta, it's actually a huge difference from especially on Stimdeco, probably the biggest thing was, I'd say probably my lung function. I don't know, everything is generally better besides the random abdominal pain that I get. But it's a huge difference from when I was on Orkambi, because on Orkambi I still was having these pretty somewhat frequent hospital admissions, and since I started Trikafta, I think I've only had maybe I think one for lungs.
We can put a disclaimer on that she was missing some evening doses of Trikafta at the time.
That's true.
Yeah.
Yeah. Trikafta's being it. Sorry.
no, you're good. No, I will comment that I do think that her Pseudomonas growth is lessened over time to where we're close. We're almost at that, if not past that year mark. So we will see, Dr. Noyes. Yeah.
I think we have one more culture I've been following too.
Oh, yes, good. One more culture. She's on it. Yeah.
Lisa, I was wondering if you knew about the Simplify study and those results?
If I know about the Simplify study, well, I don't specifically, but I know tomorrow there's a session all about it. So I'll plug that. Right.
Because that might get you off of both chromosome and our hypocalcemia.
Okay.
Yeah. I'll look into it.
No, I can't speak. We have had several, in our center that we have de-escalated or have de-escalated on their own, right? So, yeah, plug for the session tomorrow.
So I have a question for Jennifer. I think that the
whether or not to go on modulators is real for families when they have a child diagnosed in the newborn period and the child is healthy. So with your experience and what you know now, is there anything you'd suggest for families or approaches to counseling families that are, that you would recommend?
I mean, definitely at this point, in hindsight, the earlier the better on starting modulators, just because, I mean, with Raina and having that purge and all that damage already done, but even then just with Kylie, if there had been any chance, maybe we could have prevented just anything that was done, or just having her weight more stable, because we did struggle those first couple of years before combi with weight. Not to the extent that Raina had struggled, but we were still struggling. So if in hindsight, I probably should have just agreed at the time that it was presented as an option, just to kind of avoid some of that.
Is there any data or is there any ways of communication that would have helped? Like, that's what I struggle with from.
Yeah, I honestly don't know, because it is from just the parent side of it. All you see is your healthy child. They have this diagnosis, but they're not culturing anything yet. They haven't been sick yet. So even as an experienced CF mom, it was even hard for me to see. So I think if they're really new into it, it's just going to be really hard to, convince them. Maybe a peer group with other experienced people would help.
And I always wonder if the family voice like yours is the most important. So if there's a way to have stories or patient stories, family stories on the CF Foundation website regarding decision-making about modulators, that might be a helpful resource.
Yeah, definitely.
Questions are rolling in. So real quick, this one, I love, Raina, they love your personality. They want to know what you want to be when you grow up.
When I grow up, okay, I'm a very indecisive person, I will say that. I do know, I do find the medical field very interesting. I'm in the Health and Science Academy at my school, and it's been some of my favorite classes have been in that. Like my old biology teacher, Mr. Potter, you're awesome. But yeah, the other thing that I was thinking about also, I think this one might be a little bit. This one would probably be less stressful. This would be if I want to. I think doing something in like music industry would be cool. Something to do with like band, maybe just minoring in like music education, I think would be really cool. But yeah, probably mostly medical field, something in that. I don't know, yeah.
You got some time.
Yeah.
People would like to know if you had any of that Trikafta initial like purge. How was it starting Trikafta? If you can recall that first week a little more.
Yeah, when I started Trikafta, I really don't recall it being bad at all. I think it was really pretty, like, I think because Symdeko and Trikafta were like pretty, in my experience, they're like pretty similar sort of. So the transition from Symdeko to Trikafta was not very difficult. But I will say, if I went from nothing straight to Trikafta, it probably would have been a lot worse, even from Orkambi to Trikafta.
Excellent. I did see a hand raised. I wanted to let you address. Yeah.
I want to know if you still have a YouTube channel.
Yes.
Well, there are some videos up. I don't still make videos, but...
TikToks, no?
I don't know. Well, I do have a TikTok, but...
It's moved on.
Yeah. I have made videos about, like, other videos about CF in the past, but they were mostly just for, like, a real short, like, time period, and my dad helped me edit them. The video you saw was an unedited version.
I'm glad.
The edited version is crazy. That's why I didn't play it. But yeah, there's a few videos. I did make a video on like changing and like replacing my G-tube when I still had that. And I also had a video on like flushing my port that you have to do every month. So I think I might have taken those down, but I might take them back up or put them back up. Yeah.
How have you managed explaining your disease to your friends?
Oh, this is an interesting question. My friends, they do all know that I have it. I usually, so actually, one of the things that I've been doing more recently is just like asking like, hey, have you seen 5 Feet Apart? And then just being like, yeah, I have that. Because usually most people have seen that movie, and while it's not like 100%, it doesn't 100% reflect my experience, but it gives a pretty general good idea. So I usually like start off with that, and sometimes I'll go more in depth. But yeah, I also tell them it would be helpful to like look it up if you really want to know more. But yeah, I don't know. I usually tell them that with my medication, I am basically a normal, like I'm basically pretty like healthy for what I could be without it.
Excellent.
Yeah.
What instrument do you play?
Okay, I play. So my main instrument is the flute. But I also have a clarinet that I can play. Right now, it's currently broken. I'm gonna take it in soon, but I do know a little bit of piano, and I know a scale on the trumpet. That doesn't mean I can play it very well. I can't hit the top notes.
Did you play it well?
No.
No, keep going. We didn't mean to do. So, do you see a difference with your playing prior and after Trikafta?
Oh, that's a good question.
Yeah.
I don't really. I think so. Yeah. Like, to be fair, there has been a really big difference in the music that I've been playing and the breathing skills that I need for it. I think it's honestly, it's been pretty like a linear line. Like, as the music gets harder, my breathing capabilities get better. So it feels like it stays the same, but I think it has definitely gotten a lot like better. Like, if I went and played something that I did in 6th grade, it would be like, I would be able to, my breathing technique would be better, basically. Yeah.
Awesome. Do you use any adherence tools for your medications?
Like apps or anything? We don't.
Oh,
Any
no.
apps for that, or-
Yeah, I don't. I just have a pill container, and I have it like all, like Sunday through Saturday. But yeah, I don't use any apps.
Awesome. Good. And we're caught up. If there's any questions from the audience, time for a few more. There is some call outs that you're such a smart and well-spoken young lady.
Thank you.
This person's only 10 years older than you, and they think that you're pretty cool. Any other questions? All right, well, we will end early. I will call my CF team up if they'll come up for a picture. Yep. Yeah, appreciate you. Yeah, good job. Hey, that's good. Let me come up and chit chat with you. Yeah, awesome. Time to eat, too.